So psilocybin, like I said, is in phase 3, and it is a very safe medicine. So in the psychedelics, most of them do not have addictive potential. Some, namely ketamine and MDMA, do have more of a potential, again, which is much less likely if you're using it in a therapeutic format. Like the way that when MDMA, if it gets approved, it will only be available as a prescription through your clinician. This is not something that you're going to be able to take home or sell on the street. Like this is a completely different paradigm.
Hi, everyone. Welcome back to the channel. Thanks for being here. Today, I am doing a really fascinating interview with the founder of the Psychedelic Medicine Association. Her name is Dr. Lynn Morski. She is a board-certified family physician, and over the last 5 years has really been focused on clinician education in the field of psychedelic medicine. So we're going to get into all the psychedelics, which ones are coming to market, which ones are going to be potentially available in the upcoming years, and what the clinical applications may be for them. So Dr. Morski, thanks for being here.
Thank you so much for having me. I really appreciate it.
Yeah, I'm really excited for this conversation. So I know we talked a little bit beforehand, but I wanted to save the juicy stuff till now. So let's just get started with some baseline stuff. What are psychedelics? What makes up the category of psychedelics when you're talking about psychedelics in clinical medicine?
So psychedelic medicine is a category of different medicines, and the one thing that's common between all of them is generally there is a preparation phase, and then you do 1 to maybe 6 sessions with the medicine, and then there are therapeutic meetings afterward that we call integration, where you take what you might have learned or what you've experienced, and then you work with an integration therapist to get that integrated back into your daily life, into your psyche, into your nervous system, all of those things. So it's very different from a lot of the traditional, take this medicine every day, where we're generally chasing the symptoms or trying to tamp down symptoms of something like depression. Whereas psychedelic medicine, you have these psychedelic experiences where you go in and you're trying to find the root of, let's say, depression and address the root directly instead of trying to just work on chasing the symptoms day after day. And this category, there are certain things called the classical psychedelics, but for our purposes, we include things like ketamine, which, yes, we all know is an anesthetic, but it can be used as a psychedelic because it actually, even more so than the hallucinations you see with traditional psychedelics, ketamine is a dissociative. There's some you feel a little bit like out of your body, but still there's some very kind of psychedelic effects with ketamine at certain doses. We also include MDMA, which is commonly referred to as ecstasy. It is also not a traditional psychedelic. You're not seeing hallucinations, but there's definitely an experience and this kind of like altered state of consciousness, which is common to all of these. Other ones that are more commonly known is psilocybin, which is the active ingredient in magic mushrooms. We're also talking about LSD, which has been called acid. We're also talking about DMT and ayahuasca and different forms of DMT, and also something called ibogaine. And so I think that covers a lot of the more common ones that you'll probably hear about in the research.
And which one of these is sort of coming more to the forefront? I know that ketamine is already being used. We did an episode actually on this podcast about ketamine and ketamine clinics. So which one, aside from ketamine, because we know that is already in use, which other ones are sort of at the forefront, and what are they going to be treating?
So the FDA has something called breakthrough therapy designation, and that's something that they give to a medicine that is intended to treat as a condition. And the requirements are that that condition is very serious and difficult to treat, and that the medicine that is aimed at treating it is showing more efficacy than traditional treatments for that condition. And so the 5 psychedelic breakthrough therapy designations that have been granted are: 1, MDMA was granted breakthrough therapy designation for post-traumatic stress disorder, PTSD. Psilocybin, like I said, the ingredient in magic mushrooms, was given a breakthrough therapy designation for both treatment-resistant depression and major depressive disorder. And a version of psilocybin, in addition, was given that designation for major depressive disorder. In addition, we also have LSD was given the designation for treatment of generalized anxiety disorder. Now, of those, the first one that I mentioned, MDMA, which is actually MDMA assisted therapy, has been applied to the FDA. And since it has that breakthrough therapy designation, they have until this August to let us know if they're going to approve it. So that may be the first FDA approved psychedelic medicine outside of ketamine and esketamine. Psilocybin is currently legal for adult use in the state of Oregon and is going to be legal for adult use in the state of Colorado coming soon. And it is also in phase 3 trials, which means that after it finishes phase 3, they can apply for FDA approval.
And so my question, just to touch on the MDA piece that you mentioned earlier, is, we hear about these drugs, and now it's so interesting because these drugs are actually they're drugs, but when we talked about them, they were like the party drugs, and it wasn't considered therapy in any way whatsoever. It was kind of considered a recreational use drug. So how is the use of MDMA different in these trials? How are you, well, not you, but how are clinicians and the regulatory system protecting against some of the things that we've seen happen that are negative with recreational use of drugs?
Absolutely. What's important is that when we're talking about psychedelic medicines in this therapeutic context, we're talking about one, generally they're used in conjunction with psychotherapy. Not always, but very often, like I specifically said a minute ago, the FDA approval would be for MDMA assisted therapy. Like the therapy is part of what they have applied for. And the other important thing is set and setting. Set refers to the mindset that you have going into the experience, and setting is the physical setting. Like, are you in a safe place, not too overstimulating? Maybe you have eye shades, which helps you go inward. Maybe headphones with like a playlist that's curated to your experience, as opposed to at a rave, dehydrated overnight, other people, multiple substance use, right? People that are drinking and taking the substance or polysubstance, right? This is a much more controlled situation. There is a therapist or a clinician of some type there the entire time. You have been clinically screened, you are monitored. All of those things are to increase efficacy and safety.
Okay, so it looks like that is kind of on the forefront, MDMA assisted therapy on the forefront of being approved or possibly approved. I know we can't really say that until we know the answer, which will be in a few months. What do you think is going to be next on the horizon after that?
So psilocybin, like I said, is in phase 3, and it is a very safe medicine. So in the psychedelics, most of them do not have addictive potential. Some, namely ketamine and MDMA, do have more of a potential, again, which is much less likely if you're using it in a therapeutic format. Like the way that when MDMA, if it gets approved, it will only be available as a prescription through your clinician. This is not something that you're going to be able to take home or sell on the street. Like this is a completely different paradigm. But psilocybin, as I said, which is the ingredient in magic mushrooms, it's really safe. No addictive potential so far that they've found. It just stops working if you take it more than a few times in a short period. So it's got a good safety profile, and it's showing efficacy across so many different realms: major depression, treatment-resistant depression. They're investigating it for cluster headache, migraine, eating disorder, OCD. There's so many things that they're looking at psilocybin for. So I think once that gets FDA approved, it's really going to expand the options of things that we have available to us through psychedelics. And the length of the journey is pretty similar between MDMA and psilocybin, somewhere between 4 and 8 hours. And so I think a lot of the systems that will be put in place for MDMA assisted therapy will work for psilocybin assisted therapy. So hopefully that will pretty seamlessly work itself in once we've got FDA approval for that as well.
On the last episode that I did on ketamine, it was basically the doctor was telling me that typically it's about 6 sessions. You would also mention that it's usually session based. What are the traditional sort of protocols or the potential protocols that we might see coming out of this in terms of, okay, patients are generally going to need this many sessions, and then we're going to have 50% penetration or 80%, or what kind of numbers are we looking at when it comes to how much and how often these patients are going to need to be treated to see a real effect on their mental health condition?
So as you mentioned, for ketamine, it's very often done in that 6 sessions within 3-ish weeks. With psilocybin and MDMA, it's usually 2 to 3 sessions. With something like ibogaine, which is probably the most powerful, very often it's 1 session. And the psilocybin and MDMA sessions can be done within a couple of weeks or so, and preferably, maybe with some therapy within. But for example, one of my favorite studies is psilocybin for smoking cessation, which I did not even list in the potentials, but it was the first NIH grant for psychedelics in 50 years, because the preliminary studies were so positive. 60% of the patients, when they did psilocybin for 2 sessions plus cognitive behavioral therapy, were smoking abstinent at 16 months. 60%. No other, they're not wearing the patch, they're not chewing the gum. They did these 2 sessions with cognitive behavioral therapy. We, those of us in primary care, we know that's an incredible result, because smoking cessation is very difficult to achieve. So most of these you're seeing between 1 and 3 sessions initially. They're finding that, ketamine, I'm sure he mentioned, generally needs a booster, maybe a couple of weeks or a couple of months down the road. Some of these other psychedelics seem to be able to go a little bit longer, maybe 6 months or a year. So you may need a booster at some point. The jury is kind of still out as to whether the booster needs to be the full psychedelic experience again. There are a number of companies that are working on non-hallucinogenic versions of these psychedelics. Meaning, could we just go inside and work on the neuroplasticity and boost that back up again? And as long as you're still seeing your therapist and doing the work, will that be enough to kind of boost the effects? Still unsure, but it's seeming that like 2 to 3 sessions of most of these is working. And with the MDMA for PTSD, the phase 2 studies, which have this year-out data, I think that, something like 60+% at 1 year did not even qualify for a diagnosis of PTSD. And there was no booster. They had done the 3 sessions, 2 or 3 sessions without a booster. At 1 year, they still are basically no longer having enough symptoms to qualify for PTSD. So that's the numbers we're looking at, is just, a couple sessions and then perhaps some booster down the road.
And what about the therapy? Is that ongoing?
I don't know how long in these studies, they obviously give them therapy for a certain period of time, but like the ones that they're following at a year out, they're not doing the therapy the whole time. But I'm pretty sure that, the patients going into these trials, these PTSD trials specifically, had like refractory PTSD. So I'm going to assume that they have a therapist, right? That they've been working with going in, like that is, I mean, I'm just going to be bold enough to say that I think basically everybody at this point should probably have a therapist, just like we can all use a personal trainer at the gym. We could all use a mind trainer, right? And so anybody who's using these to address one of these more serious mental conditions, major depression, treatment-resistant depression, we are hoping still has a therapist. So it may be different from like the specific integration therapist that they worked on just to deal with the psychedelics. But if you're still in therapy, working on, addressing limiting beliefs and all the kind of things that may be causing the depression, or the, maybe continuing to look at that original trauma, whatever it is, we're hoping that continues. So to that point, actually, there was a paper that came out in Nature that showed psychedelics reopen our critical learning periods. And the critical learning periods, are like when you're a kid and you can pick up like 7 languages if it's spoken around you, because your brain is just so primed to receive this information. But as an adult, that period is closed. Psychedelics can reopen that period. And it looks like in the preliminary research, the amount of the duration of the hallucinogenic period is proportional to the duration that period is open. So something like ketamine that's shorter, the period opens for about 48 hours. Something like psilocybin that's longer, it opens longer. But the key is, what do you do with that period, right? Like your brain is now ready to get new information. Let's go to therapy and learn that we are not this identity we've built. We're not our job. This trauma that we had doesn't define us. The things that, whatever came from our childhood, negative beliefs, it's time to like rewire the brain, because we can. And so that's what's really important, is that like, yes, it's really important afterward in the immediate period to make the most of that. But that's what they're thinking, is if we can perhaps down the road with some of these, they don't have to go through the 8-hour, hallucinatory journey. If we can still kind of boost that neuroplasticity and still keep working with that therapist, perhaps that will ignite those effects.
I want to go back to what you said about the smoking cessation, because that's pretty powerful. So is that approved? Is that in use?
No, so it is being researched. So the original studies were done at Johns Hopkins showing the results that I told you about. I think that was back in 2018. And in 2021, I believe it is, the NIH gave a grant to further that study, to study that in a larger population. And so that study is in the works. But that I do not know. See, the FDA process is very complicated because it takes a lot of money. So these things can be researched by an organization, something like Johns Hopkins, but to actually get FDA approval takes a lot of money to go through the phases, right? And so I'm not like a business specialist, so I don't know who would take it from, passing the grant through the FDA approval process. However, as we know, as clinicians, once something is approved, ketamine's a great example, then there can be off-label use. And so, perhaps, they approve it for major depressive disorder, treatment-resistant depression disorder, or treatment-resistant depression, then, we've got this tool that perhaps can be and it always depends on what the REMS say, because a lot of these, we're suspecting that if MDMA is approved, it will come with a REMS, which is the risk evaluation and mitigation strategy, which says exactly who can use it and exactly how. But there's a lot of comorbidity there. We know a lot of people with depression who may be smoking, and so hopefully, if we can treat them for one and it happens to treat the other, that would be a great side effect.
Yeah, I'm just thinking about the economic impact of a, fairly short way to potentially stop smoking. I mean, that could have really crazy ripple effects when it comes to not just the cigarette industry, but the patch industry and, I mean, decreased rates of lung cancer and the kind of really long-term effects that something like this could have, which is really, really fascinating because when you start to rewire your brain, that's really when, you can, I feel like, stick to something because, those addictive behaviors need to really be sort of, the patterns need to be changed. Have have there been any studies on alcohol in this?
Yes. Psilocybin has also been shown to be effective for alcohol use disorder. So it was a study out of, I believe, NYU that showed that the percentage of binge drinking days in this population that they studied was significantly lower, and for a fairly extended period of time in those who had done in the psilocybin arm versus whatever the placebo arm was that they used. So yes, I'm glad that you brought that up. One of the biggest things that psychedelics have been found to kind of as an entire class address is addictions of many types. Ibogaine that I had mentioned is really effective for opioid use disorder. And that's something that very few things are effective. Like there isn't that withdrawal period if the patient does the experience properly. So yes, tobacco addiction, alcohol addiction, I think they've looked at as well, cocaine addiction, opioid use. And then there's even a study going on with, I believe it's either psilocybin or MDMA for methamphetamine use disorder.
What about food? Because, food can be an addiction too.
So as I mentioned, they're looking at psychedelics, namely psilocybin, for eating disorders. And so binge eating disorder may be one in there. And so, yeah, it absolutely, there's a number of things that lead to addiction, but a lot of them is lack of connection. And then there's the perhaps limiting beliefs, perhaps traumas. And then there's the actual the way that the dopamine receptors are and all those. But it'll be interesting to see the different ways that psychedelics on a cellular level and with proper therapy and that rewiring can have beneficial effects on those addictions.
What's your opinion on why this has taken so long? Because these drugs have obviously existed for a very long time.
Oh, stigma. It's not even it's just like fact, right? Like, so once Nixon made them illegal in 1970, and then, you and I grew up in the Nancy Reagan Just Say No Dare program, right? And so like there's this is your brain on drugs commercial that we all saw. And it's funny because actually, if we're talking these, psilocybin, some of these other psychedelics, your brain on drugs is actually significantly more lit up and connected and has for all those clinicians out there, like, neuroplasticity is what's fired up in most of these, but there are even some that are shown to promote neurogenesis, the growth of new neurons. And so there are even studies on DMT, which is a psychedelic for stroke recovery. And so it's like they're growing new neurons in the hippocampus, right? Like new memories can be formed, all these things. So, it was just politics and propaganda that led us to think that all drugs are the same. And here I want to make the point that, I'm not trying to say these are better than other drugs. I'm just pointing out, because unfortunately a lot of drugs get demonized and then the people that use them end up incarcerated, and that's not beneficial for them either. But a lot of it is, like we said, set and setting. These are the ones that we are finding have low abuse potential, low addiction potential, and that when put in the proper set and setting, they have these potential benefits. But yeah, it's just been stigma and misinformation. And so it's, very grateful to the pioneers of the like new wave of psychedelic research who had the courage to say, like, no, I want to go to the DEA and get a license to study these Schedule I substances.
I know you said psilocybin is extremely low risk. Can you talk to me about any potential risks with psilocybin, as well as the other drugs that you mentioned?
So a lot of these raise your cardiovascular state, heart rate, blood pressure. If you can imagine having, an altered state of consciousness, there may be like an excitement there, and there's also just like this kind of overall activation. And so that's the primary physiologic effect that it has. Psychologically, we're still investigating whether these are safe in people who have something like schizophrenia or a psychosis disorder, because the way that your brain starts to light up is a little bit similar to the way that it would light up during a hallucination, obviously in a psychosis. And so we're unsure how safe it is in those scenarios. Um, Otherwise, if you're in a safe set and setting, then like the physical dangers aren't so much, right? Like, when you hear horror stories, this person jumped off a bridge under while taking acid. Well, they shouldn't be near a bridge, right? Like that was so unfortunate about the Matthew Perry situation is, he had ketamine in his system in a pool. Absolutely not advised, right? Like that's not where we're doing ketamine therapy. And so, risks are significantly lower if your physical setting is safe. And then there are, psychiatric risks that come that you don't have to necessarily have any kind of, predisposing whatever, but like there are challenging, some people might say, what about bad trips? Well, the slight reframe on that is there are challenging experiences. Now, we kind of used to say like there is no bad trip, just a challenging experience that you will learn from. But unfortunately, there are some people that do experience some lasting destabilization from some of these powerful psychedelics. It has yet to be seen if that is very likely in the clinical settings, right? Like, how often does that happen in these clinical settings where we know that the dose is pure and monitored and they've had therapy versus people who've done it, recreationally? But it's just always good to remember that, like antidepressants are not without risks, right? Psychedelics have some of those risks too. They look a little bit different, but they are there. But like I said, overall, the side effect list and the risk list seems to be lower than with a lot of other medications.
So is there some type of monitoring that happens, or do you anticipate that these patients in the setting would be like hooked up to a blood pressure cuff, or would that just be a contraindication if you have high blood pressure to have one of these therapies?
So I think so, it's different because a lot of these are still just in study, right? So we haven't seen what happens in regular practice. I know a lot of ketamine clinics but you had the gentleman on before. They often, if you're hooked up to an IV, will leave a cuff on. I haven't seen that they necessarily leave cuffs on normotensive patients who don't have hypertension in these other studies. I think they have probably, because they are clinical studies and they do want to have kind of a homogeneous population as far as physical health goes, I think they probably kept people with uncontrolled hypertension out of the studies. And so I think that that's been kind of just a contraindication up to this point. And it's, that's one of the discussions is what will monitoring look like? What will be required? If the patient doesn't have a history of high blood pressure, you don't need to have a cuff on. And anything you have on is going to have some effect on the ability to, get yourself maybe into completely, I recall I had been to a ketamine clinic and I tried it, and you're kind of in your journey that all of a sudden the like cuff fills up, right? It can bring you out of whatever you're doing. And so they want to have as few attachments and impediments and sounds that are medically reminding you that you're in a medical setting as possible. But it will be interesting to see what ends up being required, because we do want to have this available to the widest range of people. So we don't want people with hypertension to be kept out. But perhaps just those with uncontrolled hypertension are, we have to get the hypertension under control first.
Hi, everyone. If you've enjoyed this interview thus far, be sure to hit the like and subscribe button below. It not only helps the channel, but helps out all the people that we interview. Thanks for watching. So, of course, FDA approval is one thing. Then comes insurance coverage. So From my knowledge, ketamine therapy for these indications is not covered by insurance. So do you think the same thing is going to happen if these drugs are approved in that category?
So the issue with ketamine is that the majority of it is off-label use, meaning that when you apply for FDA approval, they approve it for some type of use. So there is one version of ketamine called S-ketamine, which is known by the brand name of Spravato, and it is FDA approved for treatment-resistant depression. So if you're a patient with treatment-resistant depression and you go to get Spravato, it can be covered by your insurance because insurance covers things that are used for their on-label use. That's the issue with most ketamine being used. Ketamine is a generic, and so it's an anesthetic. And so they're like, well, if you're not using for anesthesia, that's an off-label use, so we're not going to cover it. Now that is changing. Different places are, working very hard to get ketamine coverage for their patients because it is so effective, especially if you learn nothing else from this podcast. Ketamine is effective for acute suicidality. So, they're like, why would we put somebody on an SSRI for 6 weeks, which is covered by insurance, who's acutely suicidal may not have 6 weeks, right? Ketamine can work between 1 to 3 days for those patients, not covered by insurance, right? So when MDMA gets approved, let's say it's approved in this August, it will be, its on-label use will be PTSD. And so in theory, if the insurance companies believe that it is cost effective for them, they will cover it as an on-label use. Now, this brings up a point that you alluded to earlier, which is how these can impact financially an entire system. If you look at the disability with PTSD, I worked at the VA for 9 years. I saw that so many people come in applying for disability based on PTSD. A lot of healthcare dollars go towards, from the government to our veterans who have got a lot of PTSD from all of the exposure they've had. And that goes for those outside of the military as well. And so we're putting a lot of money toward disability payments for those who cannot work because of PTSD. And so if we find something that can bring them out of PTSD, allow them to return to the workforce, no longer need disability, this is really cost effective for us as a society. And so when you look at the price of MDMA assisted therapy, which at this point is, $10,000 to $25,000, depending on the estimates, again, because it's not yet approved, we're not sure, but it probably won't be cheap because you need therapists there for that 8-hour period. But is it more expensive to do that once versus having somebody be on disability perhaps for the rest of their life? Like, these are the kinds of things that we're hoping the insurance companies weigh and factor in. Like, do they want to pay for somebody to go to a therapist and have 2 medications for the rest of their life for PTSD? Or do they want to pay for this more of a 1 or 2 time therapy that is a little more expensive, but much more efficacious?
Yeah, so basically, with the ketamine that's being used in a lot of the clinics is generic, and that's why it's not, but it's the same thing. It's just the insurance companies are like, well, it's not the one that's approved, so we don't need to cover it, basically.
Yeah, the one that's approved this is so nerdy, but it's like the enantiomer, there's a left and a right version. It's the left version of the, like the mirror image molecules. So they, pharma companies are smart. They know how to just make little tweaks so that they can patent a thing. But here's, the reality of bringing a medicine to market. FDA trials are very expensive. Anybody who's going to put in that much money wants money at the end. So they want something they can patent.
Right.
Ketamine is generic. Nobody really has an incentive to take a generic medicine that they can't patent. It's already off patent. So what are they going to, how are they going to make money on that? So they haven't brought it through the FDA process at this point. And so that's why, unfortunately, it's an off-label use still for most things.
This is so fascinating. Switching gears a little bit, I want to talk about how you created this association, because that is a big deal. And how did you come up with the idea? Who did you approach? What was your process in getting this actually formalized?
So I was a doctor at the VA for 9 years, and somewhere in there is when I learned about psychedelic medicine and how efficacious it was, especially for the veterans and service members that I was seeing. And I couldn't tell them about it because these were, mostly illegal substances, and I was a Department of Defense employee. And so at some point, it just became very out of alignment for me. I thought, like, first, do no harm. I'm just doing harm by omission. So in 2019, I just left the VA and I made it my mission to spread the word about psychedelics to clinicians, but I didn't know how I was going to do that. At the time, I had another podcast and I thought, well, what if I just start? I know how to podcast. So if I start a podcast and I'll interview the experts, and through interviewing them, I'll learn. I'm still not an expert on psychedelics. What I know is what doctors don't know. And that's what I help to bridge the gap there. But I started a podcast, and it still exists. It's called the Psychedelic Medicine Podcast. And initially that was aimed at educating clinicians, but then I realized that clinicians don't have 45 minutes to listen to a podcast to find out if psilocybin is good for depression or if ketamine is good for PTSD. And I found out that they do have, enough time to check their inbox. And so I wanted a way to get into clinicians' inboxes. And so a friend of mine suggested, how about you start an association? And so I started thinking about it, and then I got very lucky that there were some well-connected people who wanted to start a psychedelic CME course. And when they came to me about that, I said, oh, I'm happy to help you with that. But I'm thinking of starting this association. Could we maybe, promote the course to this association? They said, forget the course. We'll help you start the association. And so they gave me somebody to be my co-founder. And I just got very lucky that I was handed a CTO. And, neither of us made money for probably a year or so. And we still, this is neither of our full-time jobs, but we've been able to slowly grow. At the beginning, we didn't know anything about nonprofits. And so we just weren't one because they're so much more difficult to set up. We're a public benefit corp. So we just applied to be a PBC, and then we just existed. But since we weren't, we couldn't get donations, and we weren't the kind of people who were, the kind of organization that investors would invest in. And so we've just been surviving off of what our members pay. We have individual members, and we also have organizations that pay a little bit more to be members. We just launched a sponsorship program so that organizations can support us even more and get more visibility to our members. But yeah, that's how we just started and grew it from there.
That's pretty amazing to just kind of come up with that idea and be able to execute on it. So, congratulations to you guys. And so I can see how having a central place is pretty required in medicine. Like with almost every field of medicine, we have those central agencies, and building out those boards of experts is important. And so how are you sort of building out your medical expert board, or who else is involved in sort of inputting their expert opinion so that you guys can have this sort of so you can have a well-rounded association?
So we had two different ways that we ensured that our members had a well-rounded education. First, when we built out our board, we looked at who was active in the psychedelic industry and across different disciplines. So we are open to clinicians of all types: physicians, nurse practitioners, PAs, RNs, therapists, social workers. And so we wanted people from all those different disciplines. So we have a social worker, we have a PhD who's done some research, we have a PA, an NP, we have all kinds of, sorry, I didn't mean to say PA, we have an NP, and we have physicians. And we wanted people who were active in the industry, but who came from a lot of different clinical backgrounds. But then the ways that we educate are two or three primary ways. That we started off by sending newsletters, like these research bulletins every month, that had the 5 or 6 most updated findings, clinically applicable findings from psychedelic science. And that we could do just, my co-founder and I could do that. But we wanted, once we had like a critical mass, we wanted to start doing deep dives. And so what we do now every month is we have a webinar, a members only webinar, where we do a deep dive into one subject. And the people who staff those are the people from our organization. So we have over 100 organizations who have joined as like organization member, or I guess as member organizations, and they will be specialists. Like last month, we did a deep dive into 5-MeO-DMT, which is a psychedelic, and we have member organizations who focus on 5-MeO-DMT clinician and practitioner training. And we have people on their board who knew the neuroscience of 5-DMT. So we invited them to come do the deep dive. And so that's one of the benefits of joining and now we are moving to a sponsorship method. But when you sponsor as an organization, you can be on these panels. And so that helps us teach our members, but also helps the organizations get visibility to our members. So like every once in a while, we'll do one on how to legally speak to your patients about psychedelics. And so we have law firms that are member organizations, and they'll come on and they'll tell our members their legal expertise. But then if our members are looking for maybe somebody to help them set up a practice, or maybe have a malpractice issue, then they know the lawyers to go to who are familiar with psychedelics. And so it hopefully works out well for everyone.
Dr. Morski, thanks so much for being here. Super fascinating discussion. Really interested to know what's going to happen in this space over the next year or two. What is a website that we can get more information, or anyone who's watching that's interested in learning more about this, where can they head?
Well, thank you so much for having me. I could talk about this all day, so I really appreciate you giving me the space to share a little bit more about psychedelic medicines. And for clinicians who want to learn more, the Psychedelic Medicine Association can be found at psychedelicmedicineassociation.org. And for those who aren't clinicians but want to learn more, I have a podcast, like I said, called the Psychedelic Medicine Podcast, which you can find. It's at plantmedicine.org, but you can also find it on all podcast platforms.